Oh hey, welcome back to the workstation. I have a very interesting and classic case of an abdominal mass today. This is one of the very uncommon cases when we can actually make a complete diagnosis without using iodinated contrast. So we only need an unenhanced CT scan of the abdomen to make the diagnosis. This is a case of a young female who had been feeling something odd in her belly. She said her belly was increasing in volume on the past few months, and she could feel some kind of mass with her hand when she pressed deep into her lower abdomen. But she was feeling okay. It was painless, so she couldn't care less until she felt a very intense, excruciating pain, and she went to the ER and had a CT scan. So in this setting, this hospital, they usually do unenhanced CT scans first. We reported, and if contrast enhancement is needed, we should communicate the staff, and they would call back the patient and do the next, the other enhanced phases of the scan. In this case, luckily, there is no need for iodinated contrast to make this classic diagnosis. I'm really sure you're gonna enjoy it. So let's see the images. So this is a young female, a CT scan of the abdomen, and we are looking for a palpable mass on the pelvis, a acute abdomen, a acute painful abdomen related to a mass, a lower abdomen, a pelvic mass. So if it's your first time here, just a quick recap. This is a CT scan, a computed tomography scan. Computed tomography is a modality of axial imaging. So these are cross-sectional images, axial, transverse images. The patient is laying flat on her back on the scanner table. She goes head first into the scanner, and you have to picture yourself as if you were sitting by the sole of her feet looking forward. So this is anterior, this is posterior, this is left, and this is right. These are the breast, this is the spine, these are the rib cages, these are the bases of the lungs. So in a CT scan of the abdomen, we make cross-sectional images from the base of the lungs to the floor of the pelvis or the hip bones. So this is it. This is unenhanced. This is the only series of images we have, and we are looking for a large palpable mass on the pelvic cavity, for some reason a acute one. And as I have already told you, this is a classic case. We can make the diagnosis without the need of contrast enhancement. So this is liver and spleen. So let's go downward. These are the kidneys, kidney, right-sided kidney, left-sided kidney. Let's go downward. And we already can see, can you see it? I already can see the palpable mass in question. This is the bladder, the urinary bladder, right here. This is approximately the uterus. This is the uterus. And right above the uterus to the right, we can see this densified region right here, which is odd by itself, shouldn't be here. This is really odd. And up from there, cranial to there, we see this very, very large mass occupying a very significant portion of the abdominal cavity. This is right flank region, the mesogastrium, where the belly button is, and the left flank. a bit lower, we can already notice this is the right iliac fossa and the hypogastrium. So this is a very large intracavitary lesion. So it's a lobulated lesion. Let me measure it. This is 14.1 centimeters or 141 millimeters from left to right, and from anterior to posterior it's about 93 millimeters. So it's a very large lesion. Let's hit the multiplanar reconstruction just to have a better picture of it. I know you guys enjoy multiplanar reconstruction. This is really large and a heterogeneous lesion. We can readily see there are numerous densities. There are areas of different densities within this lesion. We can see this is a cystic attenuation, which means attenuation of fluid, 13.5 Hounsfield units. This is clearly adipose tissue, much similar to the subcutaneous fat and the intracavitary fat. So this is fat. We can also see that the walls are very thick. There are thick septations also, and there is a very distinguished solid component. So let's measure the density, the attenuation of the solid component. So 63. So we have right here cystic, solid, adipose tissue. So we have 3 attenuation, and also we can see calcification. These very bright spots are calcic, are calcium attenuating lesions. So this is almost 1000 Hounsfield units. And if you are very careful and experienced, you can readily see that these features, these calcified features, have a very distinctive shape. This looks so much like a tooth. This is a tooth shape calcified lesion. This is actually a tooth because this is a classic cystic mature teratoma, also known by monstrosity, a monstrous tumor. This is a germ cell tumor, a tumor usually originated from the ovary that has all the fundamental components of a human body. It has adipose tissue, soft tissue like muscle and other hair, and it has liquid fluids of all kinds, oleous components, and it has calcified components. When it's really mature, histologically speaking, it has even distinct bone structures such as tooth, just like this. So this is a mature cystic teratoma. And as I have described to you until now, we can readily make this diagnosis of a cystic mature teratoma because it has a classic presentation. It's a large mass with all these components I just explained to you. But knowing it is a tumor, it is most probably of ovarian, it's from the ovary, it still doesn't justify the acute pain the patient is complaining about. So why is she complaining about pain? Remember, we saw this odd densified serpiginous lesion right here. This goes from the right cornwall side of the uterus and goes up and joins together with the lesion. So most probably this serpiginous lesion tortuous, thickened, and bright lesion right here is a twisted parametrium, a twisted uterine tube, fallopian tube. So this is most probably the most common complication of a large ovarian mass, a ovarian torsion, a acute torsion of the mass, which leads to infarction and acute pain. So this is a large pelvic mass, most probably originated from the ovary, with a clear diagnosis of mature teratoma that has suffered a torsion and is now causing pain due to a ischemic situation, a acute infarction of the parametrium. So this justifies the palpable mass and the pain. From this moment on, as soon as we get this diagnosis to the surgeon, he is going to schedule a urgent surgery to take the mass off and cure the patient both of the pain and the tumor. Usually this is a benign tumor, and the patient after the surgery shouldn't care much about any kind of recurrence or metastasis. Also, we can tell this is an acute abdomen because we have densification of the fat, the intracavitary fat, just like this. We know this fat right here is much different from the normal fat of the subcutaneous tissue, and there is free fluid all around the abdomen, around the site of torsion, the site of the lesion. So we can easily say that this is an acute abdomen, a adnexal, a parametrium torsion due to the presence of a large ovarian mass, which is very easily diagnosed as a mature cystic teratoma. So if you enjoyed this video, I'm pretty sure you're gonna enjoy this one right here. Just click and keep watching. Thank you so much. Like, share and subscribe, and I'll see you in the next video. Take care.